Sir, we are starting, sir. Sir, we are starting the webinar now, sir.
Okay.
Yeah. So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So the topic for today's webinar is urinary tract infection in pregnancy. And I welcome all the participants and I request them to post your queries in the comment box so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. MC Pratihar, sir. Sir has graduated from BS Medical College, Bankura from 1972, and sir has completed a DGO from Chatranjan Shivasdan College of Gynecology and Child Health in 1975. And sir has worked as a medical officer in West Bengal Health Service. And sir is now retired and engaged in his private practice. So with this short introduction, I welcome you, sir, and I'm handing the session to you, sir, for further proceedings. Thank you, sir. Ma'am, you can share your screen now.
Hello, friends. Today's topic is urinary tract in pregnancy. What is urinary tract infection? Urinary tract infection is an infection of any part of our urinary system, including kidneys, ureter, bladder, and urethra. Most infections involve the lower urinary tract, the bladder, and the urethra. By convention, UTI, that is urinary tract infection, is defined either as a lower urinary tract infection, that is acute cystitis, or upper tract infection, that is acute pyelonephritis. It may be subclinical, that is asymptomatic, or symptomatic disease, that is causing symptoms. Thus, the term UTI encompasses a variety of clinical entities, including asymptomatic bacteriuria, cystitis, and pyelonephritis. Acute bacteriuria, bacteriuria acute bacteriuria occurs in the absence of symptoms attributable to the bacteria causing damage to the immune system. This condition, acute bacteriuria in the urinary tract, they do not cause symptoms, but they require treatment. Urinary tract infection has more typically been assumed to imply symptomatic disease. Disease treatment is mainly antimicrobial. Now, types of urinary infection and responsible organism. The main organism is E. coli. Others are like pneumonia, Staphylococcus aureus, Candida, etc. Main is Staphylococcus, E. coli, that is 75% about. Risk factor for us asymptomatic cases, female gender is common, older is going to be more vulnerable, and younger age also. The risk factors for the complicated UTI, indwelling catheter, immunosuppression, urinary tract abnormalities, or antibiotic exposure. In pregnancy, most common bacterial infections during pregnancy is asymptomatic bacteriuria, is most common. Pregnant women, this ABU or symptomatic bacteriuria has clinical consequence and both it is asymptomatic bacteriuria, though it causes no symptoms but requires treatment because it may progress to the clinical condition. Specifically, acute bacteriuria during pregnancy is associated with preterm birth, perinatal mortality for the fetus, and during pyelonephritis. Now let us survey the conditions. This asymptomatic bacteriuria is usually around about 10%, acute cystitis 1 to 4%, acute pyelonephritis 0.4 to 2%. Though incidence of bacteriuria in pregnant women is only slightly higher than that of pregnant women, the chances of progression to pyelonephritis is significantly higher, that is 40%. Rate of occurrence has not been calculated by the RCT or major study. Okay, let us go to the next. That's the causes. Normal perineal flora, E. coli, Klebsiella, Proteus, Heterobacter, Enterococcus, and for the complicated UTI, all the above organisms plus Acinetobacter species, Pseudomonas aeruginosa, etc. Now let us come to the body resistance or host resistance so that bacteria cannot either they cannot make colony or either they cannot cause any disease. So there are host protection or immunity, one by the flow of urine and another by mucosal immunity, that is the lining membrane of the urethra. So this, how the urine causes difference. It is acidic in reaction. That is, most pathogens cannot survive in this acidic media. And high urine osmolarity. Thirdly, urinary inhibitors or bacterial adherence. Urine contains some chemicals which inhibits the bacterial adherence to the mucosa. Competitive inhibitors of attachment to epithelial cells. Other quantity inhibitors are usually urinary inhibitors. There another is competitive inhibitors. This mechanical forcing of urine flow is the next thing. Next thing and last thing. This is very important. It is urine flow amount decides that they cannot adhere. Now the mucosal immunity. Urothelial secretion of cytokines and chemokines to polysaccharide lining increases difficulty of bacterial penetration. This mucopolysaccharide lining over the mucosa bacteria cannot easily get into it. Another thing is mucosal Ig, which is immune substance. How the process occurs in the urinary tract infections. At first, these bacteria they colonize in the urethra. I know the main source is perineal flora, so they colonize at the entrance of the urethra opening and in the urethra gradually substance. They are by localized in different now. This urinary tract system, it is very close to genitalia. Also, behind that is the rectum. Next, this is the anatomical description. Clinical presentation, the most common form of recurrent UTI is recurrent or persistent asymptomatic bacteriuria. This is the most common form. Or acute pyelonephritis after an untreated primary asymptomatic bacteria. It is where the asymptomatic condition they gradually progress to the pyelonephritis or cystitis. Asymptomatic bacteriuria is the condition that is the bacteria colonize in the urinary tract but do not causing symptoms. These colony counts are there in case of monoculture, those can be equal to about 10 to the power 5 in case of ethno specimen 10 to the power 2. Okay. This is very mathematical. It is not necessary very much to remember. Okay. Now, how do you follow the asymptomatic bacteria? All pregnant women with asymptomatic bacteria should have periodic screening after therapy, since as many as one-third of them experience a recurrent infections. We should follow up by culture. That culture should be taken about 2 weeks after treatment and then repeated once a month. Treatment of asymptomatic condition. Asymptomatic bacteria should be treated by single dose antibiotics. That is one shot, 3-day course, and others for 7 or 10 days courses. Just for example, amoxicillin, cephalosporin, nitrofurantoin can be given a loading dose and that's all. Others can be given 3 days course, those things. Cephalosporin, amoxicillin, cephalosporin, rofloxacin. Nowadays, imethylprim, sulfamethoxazole, though time on or soil. This is a 3 days course. NFT, they can be given for 7 to 10 days. NFT nitrofurantoins, they are very valuable for the failure cases. Failure cases, they can be given for 3 weeks, 4 times per week for 3 weeks. Significance. If not treated, this condition as symptomatic condition, 25% of infected women will develop symptomatic infection. During pregnancy, development to symptomatic infection is common. 25%. In some, but not all studies, bacteria has been associated with preterm or low birth weight infants. This is the condition affecting the outcome of pregnancy. Screening and treatment. Screening should be done at the pregnant period, about 12 weeks to 16 weeks time. The scan can be done, especially for those who have past history of urinary tract operation or disease, mechanical disease, hemoglobin Ace, that is sickle cell hemoglobin, or past history of liver. In those cases, rescans should be done. Rescan of the urine culture. This urine culture, the specimen should be midstream clean touch. Midstream clean touch. Diagnosis should be. Treatment is mainly antibiotic according to the result of the culture. Next, for those women with persistent or recurrent bacteriuria, prophylactic or suppressive antibiotics may be given in addition to retreatment. Prophylactic antibiotics or drugs are very important for those. Now let me the common condition, acute cystitis. Acute cystitis affects approximately 1% of all pregnant women. Acute cystitis in pregnancy almost always result from ascending infection in the long-standing asymptomatic bacteriuria that is coming up from the urethra. This clinical symptoms and signs of acute cystitis. Typical symptoms of acute cystitis in the pregnant women are same as in non-pregnant women. They include dysuria, urinary urgency, and frequency. Sometimes hematuria and pyuria may be associated, confirmed by urine analysis. Systemic symptoms such as fever, chills are generally absent in cystitis. These systemic systems see in cystitis as we see in pyelonephritis. This diagnosis of acute cystitis gives us the dysuria. Next, fever, chills, flank pain, and tenderness on the costovertebral angle. Urinary analysis will give us the clue, and the culture will give us the line of treatment. Prior to confirming the diagnosis, empiric treatment is typically started. Usually, if we do general examination, urine and we gave any hint before sending the sample for culture sensitivity. It is reasonable to use quantitative count in a symptomatic pregnant woman as an indicator of symptoms. Treatment is by same drugs as used in asymptomatic bacteria, as we have discussed earlier. Acute pyelonephritis, the symptoms as we saw in acute cystitis are associated with systemic symptoms like fever, hand pain, vomiting, nausea, pyuria, the typical finding. Usually, this pyelonephritis, this acute condition, appears during the second and third trimesters. They actually become ill, risk for both medical and obstetrical complications. Many as 20% women with severe pyelonephritis develop complications. Serious complication is septic shock syndrome. It is the most common serious medical complication of pregnancy. Pyelonephritis was the leading cause of septic shock during pregnancy. Pyelonephritis is unilateral, usually on the right side. Some of the cases can be bilateral. The signs of symptoms. Signs and symptoms. Abrupt onset with fever, shaking chills, aching pain in one or both lumbar regions, anorexia, nausea, vomiting, tenderness, loin tenderness, postural angle. Signs and symptoms. Now come to the diagnosis. Clinical diagnosis, that is, we arrive from the symptoms and signs after examining the patients, and then laboratory urine analysis lead us to the cause, and cultural sensitivity will give us the actual treatment. Systemic infection or urinary tract infection should be suspected with these symptoms, and pyuria may be seen in many cases. Those who are severely ill, their symptoms may mimic like renal colic, renal stones, and past history of urological surgery or personal history of immunosuppression, repeated episodes of pyelonephritis, sepsis, and even imaging of kidneys and diagnostic urographic, etc. may involve these conditions. This differential diagnosis of acute pyelonephritis. This condition is acute systemic symptoms they cause mimic the chorionitis, appendicitis, placental abruption, and infected leiomyoma. But leiomyoma sometimes may get infected with the central portion, lacks blood supply, and there is changes in the leiomyomas causing acute symptoms of acute abdominal things. Obstetric management. Obstetrics management, as it is for pyelonephritis, is nothing but things should be dealt with the condition of the pregnancy and the situation of the pregnancy. Interference, we do induction of labor, C-section. It should be planned according to the viability of the pregnancy and according to obstetric condition. And obstetric decisions should not be influenced by this pyelonephritis. Okay. We often come across preterm labor, preeclampsia, pneumonitis, and afterbirth endometritis. Fetal complications, as we have discussed, low birth weight, prematurity, developmental delay, or mental retardation, and perinatal mortality. So fetal's regressions, various types, and should be considered condition. Nephritis management, acute cases, we should admit the patient and administer intravenous antibiotics that is indicated by the culture sensitivity. And we should make a survey of chest condition if necessary. If there is dyspnea or tachypnea, we should make a radiogram of the chest. We should seal the pregnant uterus to avoid radiation effect. Repeat hematology and chemistry studies in 24 hours. That is hematology, hemoglobin TCDC or chemistry like creatinine, etc. should be done. Should be repeated. Change the condition improves. Antibiotic therapy gives the condition control. Then you can go on oral antimicrobial when the patient with an febrile. And these oral antibiotics should continue into 2 weeks. Urine should be again sent for culture sensitivity. This pyelonephritis, we have grouped antibiotics according to the mild to moderate condition, severe condition, and the conditions associated with special conditions. Mild and moderate acute pyelonephritis, ceftriaxone, amoxicillin, supine, or H3O. These are the drug structures for this moderate and mild type of pyelonephritis. The severe acute cases, Ticacillin with clavulanic acid, 3.1 gram every 6 hourly, the drug of choice. Piperacillin tazobactam, also 3 to 4 times daily can be given, meropenem can be given. Okay, these drugs should specially be used when the patients have got some immunosuppressants. Suppressants requires prompt treatment. Current treatment options for UTI. This treatment is grouped into 4 headings: to relieve burning micturition, we give alkalizers; to relieve pain and spasm, we give antispasmodics and painkillers; to eradicate the bacteria, we give the proper antibiotic culture sensitivity report; and mechanical way to flush out the bacteria. Nowadays, we are using cranberry or cranberry. During pregnancy, the antibiotics we use should be B category at least. That is amoxicillin, cephalosporin, piperacillin, erythromycin, clindamycin, meropenem, ufentanil, trimethoprim. These are the B category drugs. These are the drug options. Newer antibiotics has come in recent years, like fosfomycin. Fosfomycin is a new antibiotic that is taken as a single dose. It is taken usually at bedtime, and one should not so that you can thin in the urinary system, the plaque will pass to the urine and will form a broad spectrum antibiotic produced by certain Streptomyces species and has bactericidal action. This drug single dose is sufficient, but in case of recurrent, we can repeat every week. This persistent acute pyelonephritis infection. Generally, intravenous hydration antimicrobial therapy are followed by stepwise deprivations of approximately 1 degree Fahrenheit per day. Its temperature has to be reduced by proper hydration of the patient, by proper therapy. With persistent spiking fever or lack of clinical improvement by 32 urinary tract obstructions or another complication has to be considered. This persistent infection, other causes other than the bacteria, like some obstruction or surgical obstruction, have to be kept in mind. Causes of persistent infection. Number one cause is urinary tract obstruction. Abnormal ureteral or pyelocalyceal dilatation. Renal or perinephric abscess resulting from previous infection. Nephrolithiasis. Nephrolithiasis, stasis, is dilated condition of the urinary system, status of the urine. This leads to the microcalculate formation in the kidney and upstream. Stones. This management of persistent infection. Management of persistent infection, we should make some investigation like EVC of kidney, ureter, bladder, or if possible, one shot intravenous pyelograph or MRI. Nowadays, these advanced tests are done. Obstruction relief is important, and one method, cystoscopic placement of double J urinary stent may be required. Percutaneous nephrostomy can be undertaken for analysis and surgical removal stones. These are the management for persistent infections with their mechanical causes. What is the cause of recurrence in low count bacteremia or even negative cultures? This is the condition where urine culture cannot lead to a diagnosis. And condition has been explained that these colonies are being formed inside these cells, that is intracellular bacterial colonies, called biofilm. So the bacteria are not said and so not diagnosed by bacteria. It's biofilm, pathological condition, that is why negative culture may come. Biofilms, uropathogenic E. coli, cells lining the urinary bladder, which forms intracellular bacterial communities of biofilm. This infection remains undetected in normal urine cultures and causes recurrence. These culture-negative infections presents us as unexplained dysuria and urgency and are treated and are not treated as you cannot diagnose, but they are also termed as interstitial cystitis, bladder pain syndrome. These are all theoretical diagnoses. Okay. How we can prevent this recurrent urinary tract infections? Continued antibiotic prophylaxis till the end of pregnancy in the form of nitrofurantoin once a day can be done. Continued use of prophylaxis. Secondly, cranberry juice can be taken a long time. Maintaining local hygiene and cleanliness is very important because you know the perennial flora are the causes of ascending organisms. Drinking at least 3 to 4 liters of water per day. This urine flow, the flushing or peeling, the urothelium flushing has got a good effect for preventing. Women who are sexually active can be advised to postpartum hygiene. So these are the reasons for prevention. Now, ideal solution. Spain, burning micturition and recurrence. These three things. Spain can be reduced by arsenic acid, powerful anti-inflammatory analgesic, anti-inflammatory effect comparable to indomethacin, rapid relief from pain. This burning micturition, it can be done by neutralizing the pH of the acidified urine. Acidic urine is made alkaline. This is mainly done by potassium citrate alkalizers. Recurrence is made with cranberry extract. This cranberry extract it exerts anti-adherent property. D-mannose. These also exerts anti-adherent property. These two things, cranberry extract and D-mannose. Is used for repeated or recurrent UTI. Let us go to the next. Effects of arsenic acid. Cranberry and their constituents in human health. There are many studies to effective. Potassium magnesium citrate or alkalizer produces high concentration of bicarbonate in the urine, like the acidic urine of infected urinary tract. D-mannose is similar in structure to the binding site of urothelial glycoprotein receptor, such as uroplakin. Saturation of this uroplakin and prevent bacteria. Sufficient concentration. So this D-mannose is used to this bacterial detachment. This active ingredient of cranberry extract. Cranberry extract contains 3 types of BAC. BAC means proanthocyanidin additives. These are the chemical constituents which act. Uranthocyanidin act on the India urethral receptor that prevent here. This summary, let us come to conclusion. Urinary tract infection is an infection in any part of our urinary system. 40% of all women will suffer at least one UTI in some point of their life. So, incidence in bacteremia in pregnant women is slightly higher than non-pregnant women. The chances of progression to pyelonephritis is significantly higher, that is about 40%. High chances of pregnancy complications. First-line therapy includes antibiotics, that is safe in pregnancy. Neutralizations provide relief from pain, warning sensation, and hospital. Thank you.
Thank you, sir. Thank you very much for that wonderful presentation, sir. Sir, let me wait for 1 or 2 minutes for the participants to post their queries, sir. If there is any queries, then I will read out for you, sir. Sir, first question is, what will be the treatment option for fever due to UTI in pregnancy, sir?
Please repeat.
Sir, what will be the treatment procedure for UTI-induced fever in first trimester of pregnancy, sir?
Actually, this is not common in first trimester. This is cystitis may be there because the patients in the first trimester they take less fluid, less water. That's cystitis. In this case of symptomatic relief should be given. The antibiotics should be antispasmodic, alkalizers, that should be started. And if the urine culture shows sufficient reason, we can start antibiotic. The safe antibiotics. Okay.
Okay. And sir, we have another one question, sir. So what should be the treatment option, sir? Whether this single antibiotic like phosphomycin can be used in pregnancy, sir?
Single antibiotic, this amoxicillin is the best and safe. Or this we can give these cephalosporins. Okay.
Okay, sir. Sir, there is no other questions, sir. So if you allow us, then we can end the webinar for today, sir.
Okay.
Thank you, sir. Thank you very much for being with us today and spending your valuable time with us, sir. On behalf of Shield Healthcare, I thank you very much, and I also thank the participants for their active participation, sir. Thank you very much, sir. Sir, I am ending the webinar now, sir.